So when in terms of the workup of the patient prior and after your switching your mindset in terms of how you're going to approach or tackle this problem, do you make any changes or walk us through when a patient comes to the office for URA symptoms? What do you do? What was the talk? Just walk us through with that patient.
Yeah, so when we talk about the care pathway, it's going to be individualized, right? To your practice, your staffing, your operational systems, the hospital you work out, the healthcare system you work within. But in effect, for myself right now, I have a 2-visit pathway. And I think it really starts with using the IPSS for what I feel it truly should be. Right now, I feel like it's terribly mislabeled. It's called the International Prostate Symptom Score. It really should be International Prostate and Bladder Symptom Score. But obviously, that would be too much of a mouthful. And so actually, I've playfully been advocating we should change it to the International Peeing Symptom Score, right? I mean, at least we can keep the IPSS part. But because playfully, in many ways, at least in my opinion, and now with the recent journal article that came out this year in the Canadian Urology, in some ways, I don't think it accurately predicts the degree of BPO or benign prostatic obstruction or how severe their situation is. And playfully, it could be considered the imaginative prostate subjectivity score. We all have had guys where you're like, is that really your IPSS now that I've seen your prostate and your bladder condition or the trabeculations? How can your IPSS only be a 7? And so, but it does have a lot of value. When those guys come in, number one is I have them fill it out by hand. I want their memory of what it's been like to live with their symptoms right in front of them. And then they sign their name. They're accountable for it. And they can look at it and go, wow, that's me. And then I take it and I say, wow, that's you. Mr. Smith, I just want you to know, I'm so glad you came in today because this is a problem. We worry about you guys when that score is 8 and above. And not just because about the prostate, as it says right here, but actually a little known secret, Mr. Smith, is that it's really about your bladder health. And that's why we have to talk today because, and that's what I segue into the next point, which is critical. We have to provide a sense of urgency and a gravity to the situation. I let them know, hey, there's only 2 main organs that you can't transplant, your brain and your bladder. Your bladder is that amazingly complex that you cannot transplant that. We need to take care of it. It is that precious. And that's why, Mr. Smith, we've got to figure out what's going on here. So with that IPSS, what I do is I roll right into the 5 stages of bladder health. If you want it, we can go into that now, but I talk about the 5 stages of bladder health. And what that really does is that what I've done a lot of coaching for other physicians, other groups, the number one question I get is, hey, doc, how do I get men to do those procedures? How do I get them to choose a MIST or an IST or a MOST or a LIST? And the number one thing is we are not here to get them to do anything. We're here to guide them. We need to be their Gandalf to their Frodo. We need to be their Obi-Wan Kenobi or Yoda, right, to their Luke. And how do we do that? Like in every great story, we provide a map and we provide advice along the way. And that map, that virtual map, is the 5 stages of bladder health, right? We're trying to highlight what is at stake, which is bladder health. If the choice is made not to take definitive action about your prostate care to preserve your bladder function. And so that's what the 5 stages of bladder health, I roll into that. It's critical. We talk about the 5 stages of bladder health because then we end with like, okay, what do we need to do? Because together, we don't want you to be a victim of late stage BPH. We need data. And what does that data look like? And as you may or may not have seen my talk about how we might want to think about remodeling or re-engineering the guidelines, is that when we get to that point, there's 3 main pieces of data that we need, right? Prostate size, prostate shape, but most importantly, Detrusor function. We're big advocates. All defenders of the Detrusor are big advocates that all patients should get good bladder health counseling, talking about what's at risk, which is bladder health, that we want to prevent late-stage BPH, and then get a good bladder health baseline, assessing Detrusor function so we can risk stratify what bladders are at risk. And at that point, I'm hoping that with the guidance, the guardrails, the safeguards from the academic thought leaders that they can say, hey, so once we have risk stratified based on Detrusor function, how do we now select the best de-obstructing technology based on prostate size and prostate shape?